Hi everyone, I'm Brian Zanoni. I'm presenting this on behalf of Scarlett Burgum, part of our research team who's unable to make it today. I want to tell you about our mHealth intervention INSHA, which means youth in isiZulu, and it stands for Interactive Transition Support for Adolescents with HIV. So just some background. So retention and care for adolescents with HIV during that transition phase from pediatric-based care to adult-based care is often worse than younger children and also older adults. So in this study, I'm going to tell you about a pilot study, which was a type 3 hybrid randomized clinical trial of a mobile phone-based intervention, INSHA, and the results of the pilot. So the intervention itself was based on the SMART model, or the socio-ecological model for adolescent readiness to transition. In this model, which is somewhat complex, but you need to know that there's sort of objective factors and modifiable factors. And so we took some of the modifiable factors that you can see in that square box there and saw that some of these things we can fix and we can address. And a lot of those can be addressed with an mHealth type intervention. So we used that as our basis to develop the intervention. So it was developed using participant-centered design. We used encrypted group chats that are delivered via WhatsApp to provide peer support and to improve communications between adolescents and their caregivers and their providers and among adolescents themselves during this critical time period of transitioning from pediatric care to adult-based care. The modules came up with 10 different modules. You can see them listed there. These were all suggested by the adolescents themselves in the participant-centered design. They were topics that they wanted to learn more about, wanted to discuss more with their peers about, discuss more with their healthcare providers about, and discuss more with their caregivers about. And so this was theater tested then based on those topics that we created. So we did it live in front of adolescents and in front of their caregivers and got feedback on the intervention themselves, anything from the wording that was used, how it was presented, and the information. And then they came back to us, and with each iteration we fixed it and updated it based on feedback from adolescents, from caregivers, and from healthcare providers. So in the pilot study, we enrolled 80 adolescents. 40 were randomized to receive the intervention, and 40 were randomized to standard of care. We looked at the primary outcomes of acceptability and feasibility, and we also looked at secondary outcomes of viral suppression and retention in care 6 months after they entered the intervention. So the primary outcomes, both acceptability and feasibility, were quite high. We set goals of around 80% as being goals that we wanted, and acceptability was 82%. Feasibility dropped a little bit off at 78%. Some of the issues with feasibility were the timing of the chats that occurred. Sometimes we couldn't get all the adolescents together at the same time. There was issues with load shedding in South Africa. There were power outages and poor internet access. So even though they wanted to at times to join the session, they were unable to. There were also issues with shared phones where an adolescent didn't own their own phone, but maybe were borrowing a sibling's or a parent's, and they couldn't have access to it during the scheduled times. And then there were lost and stolen phones and phone numbers changing, so sometimes between phone numbers they weren't able to access the group chats. And then particularly in our older adolescents, those in their final year of high school or matric year in South Africa, they had a lot of studying and overlapping school activities, so they often didn't have time to attend the scheduled sessions at the time. But they often did, even though if they weren't live during the sessions, they were all on the phones, and they were still able to read through the text and the conversations that all the other participants were involved in. So our secondary outcomes is we looked at retention and care. So compared to control, adolescents in the intervention arm had a 10% increase in retention and care at 6 months. For each session that they attended during the live sessions and participated in, there was a 60% increase in retention and care for each session that was attended. And if you attended 3 of these sessions, remember there were 10, if you attended 3 of the 10, retention and care was 100%. In terms of viral suppression, there was no difference in viral suppression, and about equal in both groups, in the intervention arm and control group, but both hovering around 90%. which is still pretty good. So in conclusion, INSHA is a highly acceptable mHealth intervention that improves retention and care for adolescents with HIV and transitioning to adult care in South Africa. So I just want to thank my collaborators, co-investigators, and funders and mentors, all listed on this page, for their help in designing the study, in conducting the study, and writing up the study, and also all of the adolescents, their caregivers, and the healthcare providers that were involved in the study for their time and their patience as we were learning how to do this and how to deliver it all at the same time. So, that's it. Thanks.